So moving along, we have Lakindra Wortham. Wortham, is that right? Wortham. All right, Wortham. Lakindra Wortham. Lakindra is a licensed master social worker who received her Bachelor's of Science degree in psychology from the University of Texas at Tyler and her master's degree in social work from Stephen F. Austin State University in Nacogdoches. Lakindra provides support to her patients and families and identifies needed resources in and out of her community, of not her community, the community. And Lakindra addresses medical, emotional, spiritual, social, educational, financial needs. She's worked with the CF team since December of 2013 and has currently taken on the role as the mental health coordinator. Lakindra Wortham.
Thank you. Okay, so yes, my name is Lakindra Wortham. I'm the social worker for our Cystic Fibrosis Center and the new mental health coordinator for our clinic as well. This came about as of January this year with the Cystic Fibrosis Foundation bringing about the new guidelines on the importance of having patients and caregivers being screened for both depression and anxiety. I have no disclosures to report. So my objectives are basically to explain the purpose of the CFF's, Cystic Fibrosis Foundation's mental health guidelines, list the depression and anxiety screening assessment criteria, and describe the depression and anxiety algorithm for results and scoring, and then basically what we do once we score them, or once I score them for depression and anxiety. So if I say depression, who do you think of? Anybody? There you go. Eeyore. I knew it's too good to be true. Eeyore, when you think of someone with depression, that would be Eeyore. He is the classic person that exhibits signs, symptoms of depression. So basically, what is depression? Depression is major depressive disorder or clinical depression. It is a common but serious mood disorder. It causes severe symptoms that affect how you feel, think, and handle daily activities such as sleeping, eating, or working. So to be diagnosed with depression, you must have those symptoms present for at least 2 weeks, okay? So some of the signs and symptoms of depression: persistent sadness, anxiety, empty mood, feelings of hopelessness or pessimism, feelings of guilt, worthlessness, helplessness. You may have some irritability, loss in pleasure in activities or hobbies of things that you would normally do. You don't have any interest to do those things any longer. Decrease in energy, fatigue, moving or talking slowly, feeling restless or having trouble sitting still, difficulty concentrating, remembering, or making important decisions, or basically any kind of decisions at all. Difficulty in sleeping, early morning awakening or oversleeping. Appetite and weight increases and decreases. Individuals also have thoughts of death or suicidal ideations or even suicide attempts. Some individuals tend to have what they call destructive behaviors, what we call cutting. If anybody knows what cutting is, they'll cut their wrists, cut their legs. Basically, what they're trying to do is relieve the sense of what they're going through, that emptiness that they're going through. So they'll cut. Individuals with depression will also have aches or pains. Basically, their whole entire body aches. And that's the reason why a lot of them will just be your classical couch potato because they don't want to move. They have no motivation to do anything at all. So when I say anxiety, who do you think of? Who? Piglet. There you go. Piglet. If you ever watch Winnie the Pooh, you see Piglet. Piglet will be your individual who has classic anxiety, generalized anxiety. He's always on edge. He's always nervous, stuttering. He's just afraid of everything. So what is anxiety? Well, the thing about anxiety is we all experience anxiety in some sort of form or fashion, okay? We can have anxiety because of having to present at a conference. We can have anxiety, especially with kids or a lot of people who's going to school, and like Tara, she's going to school to be a nurse practitioner, and eventually she's going to have to take a test. Well, you can have anxiety for taking tests. A lot of people have test anxiety. I know I do. It's not a good thing. You also have anxiety when making very important decisions, such as, are we going to start a family? Are we going to get married? Are we going to buy this house? What are we going to do about this bank account? Those are things that can cause you anxiety. Those are normal anxiety. But the anxiety that the cystic fibrosis one is called generalized anxiety disorder, or any type of social phobias, okay? This kind of anxiety involves things that interfere with your work, with your school performance, and with your relationships. So some signs and symptoms of anxiety would be restlessness or feeling wound up or on edge. That would be Piglet. Being easily fatigued, difficulty concentrating or having their minds go blank. You're forgetful, you just can't remember anything. Irritability, muscle tensions. When you're anxious, you're always tense. You're always clamming up because you don't know what to expect. You have that fear of the unknown. Difficulty controlling the worrying, problems with sleeping, difficulty falling asleep or staying asleep, or restlessness or unsatisfying sleep. Okay, so some people with anxiety, as far as when it comes to their sleeping patterns, when they go to sleep, they'll wake up and then they can't go back to sleep, so they're up all night. Okay, lack of sleep can cause other problems, other issues with them. But we're not going to get into those issues. Okay, so some of the background of why the Cystic Fibrosis Foundation decided that maybe we need to do something about screening patients and caregivers for anxiety and depression. So in the last 20 years, they have made it increasingly clear that depression and anxiety are highly prevalent in individuals with cystic fibrosis, as well as their parent caregivers. The International Depression Epidemiological Study, TIDES, found that depression was 10% of adolescents with CF had depression. 19% of adults with CF had depression, and over 30% of their parent caregivers had depression. Now, the thing is that anxiety was higher than that in all of those categories. So, individuals with CF who report elevated levels of anxiety or depression have evidence of worse adherence to prescribed treatments. Basically, patients aren't doing what they're supposed to do. So you don't do what you're supposed to do, then you have higher levels of anxiety and depression. Higher rates of miss or cancel appointments. When they feel good, they don't want to come in. They come in when they don't feel good. So if you're not doing your prescribed treatments and therapies, and you're not coming to your appointments, you get sicker. So therefore, we have higher levels of anxiety and depression. Worse health-related quality of life, increased healthcare utilization, higher healthcare costs, and engagement in risky behaviors such as smoking, drinking, or drug use. So the mission of the Cystic Fibrosis Foundation, the International Committee on Mental Health, NCF, sponsored by the CF Foundation and the European Cystic Fibrosis Society, ECFS, recently developed recommendations for the prevention, screening, and treatment of depression and anxiety in individuals with CF and their caregivers. In 2013, the CF Foundation and the ECFS formed a guideline committee to develop recommendations for preventing, screening, and treating anxiety and depression in individuals with CF and their parent caregivers. So the guidelines recommend that you have preventative steps, screening tools, behavioral interventions, and medication for these conditions. So basically, preventative steps are, once they're screened, what are you going to do? Screening tools are, what are you going to do to evaluate whether or not they have depression or anxiety? So therefore, now in all the clinics up here, everybody used what we call the PHQ-9, which is a depression scale. But no one else in the clinics even here, use what we call a GAD-7. It's for anxiety. Not unless you're in the psychology clinic, then they'll use those and some other ones too. But it's important that we in the CF community is using both the PHQ-9 and the GAD-7 for screening tools. It should be recommended that all the rest of the clinics here at UT should be using the GAD-7 as well. So behavioral interventions. Okay, so once you have screened your parents and your patients, what kind of interventions are you going to do? What kind of referrals are you going to make out? Are you going to give them education? What are you going to do? And then medication for these conditions. If the scores are high enough, do you refer them over to psychiatry to either get on medications for depression or get medication for anxiety or both? Okay. So also with this guidelines, and this is a lot of stuff right here, to boil this down in a nutshell, the Cystic Fibrosis Foundation did a survey with care centers all around the world, okay? And there was concerns to why these these screening tools were not being implemented within the care centers, okay? So basically the main reasons are, one, you didn't have anyone to do them. And if you did have somebody do it, who's gonna take out the time to do it? Who's trained enough to do those things, to do these screenings? What resources are out there? What support do you have for the patients and the caregivers? So basically, that was the concerns of everyone, of all the care centers that participated in this survey. So the screening criteria. So adolescent patients between the ages of 12 to 17 will be given the PHQ-A, which is like the PHQ-9, but it's a little bit simpler, but you still, with a 12-year-old, you still have to go over it with them because they really don't understand what they're doing, so you still have to go. But you also give them the GAD-7. Screening for all pediatric caregivers will get the PHQ-9 and the GAD-7. Any adult patients, adult CF patients, from the age of 18 and older will get the PHQ-9 and the GAD-7. Both adolescent and adult CF patients will be screened annually, unless they're scored 5 or above. They'll have to retake it. Pediatric caregivers will also complete annual screening. unless their score is 5 or above. Then they'll have to retake it again. Reevaluation for patients or caregivers needed if scores are 5 above, like I just said. Okay, so this is how the PHQ-9 looks. Some of y'all should be familiar with this, if it ever comes up. Okay, so this is the PHQ-9. You have 9 questions. Of these 9, number 9 is the one that you need to be very attentive to. Number 9 is the one that thoughts that you would be better off dead or hurting yourself in some way. So if you have a patient that scores a 3 on that, you need to be calling the social worker. I'm just saying. Because that patient is having some thoughts of wanting to hurt themselves, or have had some thoughts of wanting to hurt themselves. They may not have an active plan or anything, but they may have that thought. That's why I get a lot of phone calls from the cancer center. That's just kind of what it is. A lot of people don't know how to handle their diagnosis. They don't know what to do. The world's coming to an end. And that's kind of what they feel. But once you get in and you talk to them and kind of give them a little bit of resources, they'll be okay. Okay. So, the guide for interpreting PHQ-9 scores as recommended. Okay, so if an individual scores between 0 and 4, that's a normal score. With that, you have no interventions needed, and so you reevaluate them in 1 year. If an individual has a score of 5 to 9, it's a minimal depressive symptom. Basically what you do is just offer support, education. My patients will do journaling. They have to bring their journals back to me the next time they come back in. I look at it, I read it and see what's going on. I reevaluate them on their PHQ-9. If the score is better, then we won't do anything. They can stop what they're doing, and then they'll just, I'll reevaluate them within another year. If their score is between 10 and 14, they'll have major depression, but it's mild. With individuals like this, what I'll tend to do is, 1, you're going to get education. 2, you're going to get a journal. You're going to have to start journaling. 3, you're going to get a referral to psychology or counseling. If you feel like you need to have medication or something like that, then we can do a referral to psychiatry. A lot of patients don't want medication, and I'm okay with that. If they don't want to take anything, I'm okay. But we do a referral to psychology if your score is this high. If your score is between 15 and 19, you're still major depressive, but you're moderate. So basically, you're going to do the same thing. With 15 to 19, actually from 15 to 20 or higher, you're going to get education, you're going to get journaling, you're going to get counseling, and you're going to get a referral to psychiatry. Okay. That's just my preference, because that's what I feel that you need. Okay? It's not what you want, it's what you're going to get. Okay, so this is the GAD-7. I don't know. GAD-7 is the anxiety scale. Okay, and so it's basically the same as, the PHQ-9. Okay. So with the GAD-7 scores, which is basically the same as the PHQ-9, with 0 to 4, you don't do anything, you just reevaluate them in a year. A score of 5, mild anxiety. With this, you're going to get education, journaling, and you can get a referral to counseling if needed. But if not, then we'll reevaluate your next follow-up. If your score is a 10, that's moderate anxiety. You're going to get education, journaling, referral for counseling, okay? At a 10, you can do a referral for psychiatry, but I'd rather not do that. Now, if it's 15 and higher, you're going to get all of those plus the psychiatry, which is basically the same thing. for same thing for PHQ-9. Anything above 5, you will get reevaluated your next follow-up that you come into the clinic until your scores are under 4 or 4 and under. If it's still at a 5, each time you come back in, you're going to get evaluated until we can get those scores down. Okay, so this is the algorithm that I use when you come into, once I score you for the PHQ-9 or the GAD-7, which is basically what I've been talking about. So you have a score of 0-4 on PHQ-9 or GAD-7. You will just be rescreened next year. That's pretty much it. 5 to 9, you'll get support, education, and referrals. 10 to 14, referrals, education, journaling, okay. And then higher than that is referrals, education, support, whatever you need. Now, if you have, on the number 9, that's the one I was talking about, if you have a patient who scored a 3 on that one, it may be that sometimes they may need inpatient. Because if they have suicide ideations and then they have a plan of how they're going to act out, and then they say, when I get home, this is what I'm going to do, you're not going anywhere. You get to stay here. And we're going to get a EDW, and we're going to get you placed somewhere. We're going to do that, okay? But this is the kind of algorithm that I use with our patients, okay? All right, any questions? Yes. Well, our campus police can actually do an EDW, can do the EDW here. So that's a good thing. We actually have someone that can actually do it. Now, when I worked in the actual inpatient psych facility, they usually came to my unit with the EDW, and then if they were going to stay, if the doctor wasn't going to assign them to where they could be, without it, then we'll have to get an OPC on them. So, but once they, leave from here, once I get the EDW and then I can get them placed somewhere, then that's there. But our campus police can do an EDW. Emergency detention warrant. It basically keeps them from, they can't leave, they can't do anything because they're under that. And then once they get to an inpatient psychiatric facility, then the doctor there decides whether or not they can, get off from under the EDW or they extend it to an OPC.
Since it has the word warrant in it, are they actually in some sort of police custody at that point?
Yes.
Wow. Okay.
Yes. Mm-hmm. They can't go. No, I don't. Now, the inpatient case managers, yeah, they do. No, everybody's really, on the outpatient side is a little bit better than the inpatient side. The inpatient side, yeah, they deal with that a little bit more. But I mean, because I worked in the inpatient in an adult psychiatric unit, I've dealt with all that stuff before. So, I don't have it on the outpatient side, Everybody usually is cordial. They want to go if they need to go, they'll go.
Any other questions?
All right, thank you.
Thank you, Lakindra.